we've spoken a little bit more generally about the situation and the current struggle against HIV/AIDS. Now we're going to focus a bit more on South Africa and also on the system to work with lay counsellors in trying to get the ARTs out and to make people take their pills in the right way. And for all of you who maybe are not so familiar with what lay counsellors are, get your popcorns ready. We're going to start with watching a short film.
Ekuqaleni kwendaba ngingakabi nayo ngangithi ey'nganeni mina mase ena kuthiwe ngine-HIV ngoba sengithatha izibhamu ngiduku.
When our project started in 2011, in all clinics that we were working with, we find that all patients have high viral load.
Inganakho phela siyaphuza. Awu uzobuye ngwabona kusasa.
No one was counseling clients in terms of their viral load results. So they would take bloods, but the results won't be given to them. I mean, people, they need to be reminded why they are on ARVs. Some people start ARVs while they are very sick, and when they get better, they tend to neglect their treatment.
What I like the most about my job is being able to help the clients tell their story and be able to be open about what they feel. They stop because they get into new relationships. They stop because they found a new job and they are unable to keep to the time when they're going to take their medication.
So when we do enhance adherence, that is kind of reminding them of why did they start treatment in the first place.
They will tell you, because I want to see my children going to college, I want to be healthy. If you have these goals, how are you going to achieve them if your viral load is high, because now you're going to get sick and you're not going to be able to reach your goals.
And I think that is helping them a lot because we see improvement after doing it.
Njengamanje nje ngizizwa nje ngiright kakhulu noma ngike ngaba nenkinga nga default kwakushomthisi wami la ekhaya ngingazi ukuthi ngizothathani ngihlanganise nani ngase ngihamba sengiyakulindi kayo uLindo afika hlala phansi ngase ngiyakumukela ukuthi cha Nkosi yami kufanele ngumukele njenga siphila lempilo esidla amaphilisi HIV akufanele ukuthi uthathe impilo uyifake emqondweni wakho kufanele ukuthi wazi ukuthi nje umusheshe umukele ukufaka engqondweni nje lokho ukuthi uma kwenzeke sekwenzekile. Amakhansela wasizi mina phela asiza thina esigula esidle treatment.
Asebenza impela amakhansela nakhona ngoba ngangigula nje.
Manje asazi ngempela bese ngahanjelwa yona lamakhansela ukuthi singenze njani.
Kodwa nawo mancane. Ake kuphithizele nje, phithizela amakhansela. Uthi uthatha uhobile ebhetshini likunqaka ikhansela lithi awuze ngapha wemama.
Kusho ukuthi impilo zethu ngeke zikwazi ukuthi ziphumelele impilo zethu. Kuzofiwa kunaqala. Sizofa kakhulu. Sizofa kakhulu.
It's about the work of the lay counsellors in the Eshowe project in KwaZulu-Natal. And the lay counsellors are the local health workers that help people with support to make them take the ARTs. And we were talking before the break about, can we do more with less? Can we, how to not leave anyone behind, how to get everyone aboard? And I think the work of lay counsellors is maybe one way to move this forward. And Marc Biot, who is the operational director for MSF in Southern Africa, will tell us more on how this works and what you've found in the project you've done in KZN. Welcome.
So thank you very much for organizing this meeting, this workshop today. Indeed, I think it's thanks to the Swedish postcode lottery, sorry for my pronunciation of Swedish, that we are able to join here, because that was one of their recommendations as well, to create an event with the civil society in Sweden. And I think it's very important that we as MSF can witness what happens on the field and what we can bring this out towards the public in Western or Northern countries to try to also create that solidarity link. And as I used to say, when people ask me why I do work with MSF now since 1989, it's also because I think MSF, well, I consider that we are working with our feet in the mud, but we have our head in the stars. So, and I think there's always this kind of witnessing of MSF that we try to bring from what we feel and see in the field, usually at patient level and at the lowest level of the nurses that usually don't make policy, but who are crushed by all the rules and regulations from donors to and governments towards their own reality, and that they have a little voice only in that whole game, while we try just to bring that up, to voice that out, and to try to see if we can help them, patients and healthcare workers, in their daily fight. So, and I'm very pleased and honored to bring this presentation for you. And then just, I think it's this one. Yes, indeed. So MSF started in 2011 with a project in KwaZulu-Natal. KwaZulu-Natal is that eastern province in South Africa, where also with a capital maybe less known, but the biggest city is Durban, the big port, the international port, of course, on the Indian Ocean, yes indeed, sorry. And so basically KwaZulu-Natal, why? Well, because it has, I think, the biggest prevalence of HIV in South Africa, probably also of the world. Over 30% of the adult population is infected by HIV. Program was designed after that in 2010. Some statistics and papers, interesting papers, showed that we could start looking at treatment as a prevention mean. By putting more and more people on treatment, we could also aim at preventing the spread of the disease. So that's why this project is also called bending the curves of the incidence, of the prevalence of HIV, and also, of course, of the morbidities or comorbidities due to HIV. And basically, we cater for something like 180,000 people, work around 8 health centers and 2 hospitals. And so we are specifically focused on in Umlalazi district and Eshowe and Bongolwane district, sorry, municipality of Umlalazi and the district of Bongolwane and Eshowe. In 2013, 1.5 years after we had started, we could finally also have the first results of a survey that we did in 2013, thanks to MSF and Epicentre and the government, of course, Minister of Health of South Africa. It was a study that looked at the HIV incidence and also the ART coverage, trying to understand the population you work with. I heard already several times today as well, we should look at the key populations, we should work smarter. Tobias spoke about the interesting word smarter, and he reflected already that there are some regions that should be focused on more specifically, or groups of people that should be focused more specifically, like sex workers or prisoners or migrant people and so on. But we realized some interesting issues here as well, that in the big bulk of Tobias' slides, on a certain moment Tobias showed that the general population still is probably something like over 50% of the people that we need to look for. Well, still in there are major differences according to the pattern of the the lifestyle of the person, but also the age of the person. And that is, I think, one of the biggest, how would I say, findings in that survey. So it was more or less 6,000 people that were interviewed, and so we tried to get a grip on what's happening around here. So what did we see? Well, we first saw that 25% overall HIV prevalence, so 1 on 4 of the adults are HIV positives. We have quite already a big difference, of course, between male and female, as women were double as infected as men. And unfortunately, what we also saw is that in the age group 25 to 39 years old, you have a topping up of the HIV prevalence among women. Up to 60% of the young women between 25 and 39 years old are HIV positive. Interestingly as well, you can see that as from 15 years onwards to 29 years old, this is going to climb quite steeply. Probably here explained because that's the end of the secondary school, and then gradually climbing up, and probably as well here around childbearing age, or at least, yeah, the first children are coming up, and the infection rate is indeed steeply increasing. So indeed, we see that maybe we've done already a lot, but we are maybe missing out some important parts of the population. Looking at these HIV positive people, we differentiated them between the ones that were aware of their HIV status and the ones that were not aware of this HIV status. And for example, again, looking at the group 20 to 29, you can see that the young women here, nearly half of them is not aware of their HIV status. I'm sorry, so this is not aware. Some parts of the slides have disappeared, unfortunately. And so basically what we even realize here, although in lesser numbers, but the majority of the young men are not aware of the HIV status. Something is going on here that we need to urgently focus on. So when speaking about key populations, speaking about priorities, we decided that this should be a priority, focusing on the younger age groups, focusing on the women, but also certainly not, like it was interestingly also said this morning already, focusing on the men, because also the men are escaping. Looking then at the people that are HIV positives, how many are already on ART, antiretroviral treatment, so the coverage of the treatment. So we can see here that basically, well, an interesting part, as the older we are, an interesting part of the population is indeed under antiretroviral treatment of those who are HIV positives. Again, we are missing out the younger age group, because we can see that the majority of the women and the men that are young are in fact not yet covered by antiretroviral treatment. So basically blue is the one that are under ART, the other colors are the one that are not yet under ART but HIV positive. And again here, and sorry again for the graphics, because that I think it's changed with the presentation. Basically here you can see that these are the people with an immunity with a CD4 immunity less than 350. The ones that are under 500 are up to here, and the one above 500 are up to here. So for the insiders, the people who know a little bit of the WHO guidelines, and basically until 2013, we were focusing mainly on the people with a threshold less than 350, but basically we were missing still this whole part of the population that was not allowed to start treatment. In 2013, we decided with WHO that we should, I would say, no, sorry, 2013, we should aim at inclusion criteria of CD4 500. That should be including these people. But still again, we saw that, or we can see that we would still lose quite a lot of people that would escape a treatment because of this. And happily now we know that, well, tomorrow onwards, officially it will also be recommended now in the new WHO guidelines for 2015 that we should start treatment as early as possible. This means that we will finally also be able to include all this big number of people in the yellow bars that are having still a quite good immunity, therefore also are probably more economically but also sexually active, and are the ones that are the core infectors for spreading the epidemic. Looking at the program, what does it mean now for MSF or other partners to work in an HIV program? Yes, we do focus on prevention, but unfortunately prevention is something, we'll speak a bit more in details, is something that we tend to forget a little bit too easily. And unfortunately also, 90 doesn't include prevention activities. We speak about the testing, the treatment, the linkage to care, the adherence issue. We don't have a 90 that would be tackling the prevention issues. So we are indeed trying to test the people. We are, and that is one of the biggest bottlenecks as well, is to try to link the people that have been HIV tested, HIV positively tested, that they should start treatment. They should be brought to the clinic and start treatment. And then when they are brought to the clinic, they should accept to start the treatment. This is also a thing. And then another problem is to try to retain them in care. It means that they have to come, like it was said already, or monthly, or maybe now, happily, we can already have schemes of trimestrally coming to the health centers and retained in care. But that also does not mean that they will, day by day, on the same hour, take their pills. I'm a medically trained person. I have had 5-6 years long to swallow anti-epileptic pills, and I can now know as well that it is very hard, even with all my background, medical background, very hard to oblige myself to take that damn pill every day. And that is indeed where the challenge lies. The problems is to help the people adhering daily to their treatment. It is possible, but we need to now direct our efforts to achieve so. So let's look at the prevention activities that we try to implement in KwaZulu-Natal project in Umlulazi district. And so indeed we assist the government as well with voluntary male circumcisions, because it's known that voluntary male circumcisions or male circumcisions are able to decrease the risk of HIV infection by 62% for men. Not for women, of course. And so basically, indeed, we help the government, we help the government to circumcise the people, and the men are happily already up to 1/5 of the adult age circumcised, but quite some efforts still need to be done. The next challenge indeed is about education of people, condomizing the people, of course, helping them to have easy access to condoms. But is that enough? When we see that in all these years that indeed education exists, that counseling exists, that condoms are readily present everywhere, still we can see the staggering number of women that are, or the new HIV infection, among young women aged 15 to 24 years old in East and Southern Africa, of which the staggeringly high number in South Africa of 2,363. And I'm pleased to see as well that it's the same number, I think, that Sibongile presented. So happily, these are, how would I say, reconforting, well, similar numbers. So South Africa is indeed facing that problem that education and condomization is not enough. So we are actively looking now in the years ahead to also look at PrEP. And PrEP is pre-exposure prophylaxis, trying to see that when a person, mainly a woman of course, in a certain specific time period of her life is at extreme high risk of being infected, that she could then preventively take the treatment and by this prevent the infection by a huge percentage. So PrEP is taking antiretroviral treatment while you are still HIV negative, and by this preventing you to get the treatment. So we're going to start this new innovative treatment strategy as from next year onwards. Linkage to care and testing the people. For years, in the first decade, I think, of the HIV treatment, we were focusing on testing the people when they arrived at the health center, and usually when they were asking for treatment. We gradually realized that we also should go and actively test people, even if they don't ask for treatment and they are very sick and we suspect HIV. We should also have the provider testing and testing and counseling the person. But we also realized that this was not enough, and so we have to go for looking at them at the community. And so that is what we developed in 3 different strategies. We go for door-to-door testing, but we indeed only face a certain percentage of the population there, because the majority of the people is working during the daytime, of course. But still, we can meet children, we can meet the mothers behind at home, and we indeed try to focus on the testing of this population, but that is not enough. So we need also to look at other sites, and the other sites are, for example, looking where the men are, because the men, they come back after 4 or 5 o'clock in the afternoon from work. So where do they centrally come? They are centrally coming at the bus station. So we should have fixed testing sites that are able to catch these men or these women that work on certain hours and that are only free when the health center is closed. Another problem, of course, is that they have difficulty to go for the testing, because if they would go for the testing, they would probably lose a whole day. And basically, they will also lose this day's salary because they are paid day by day. So trying to catch these people is also meaning go for them where they are. Adapt your strategies to the population that you are facing. Same, of course, for, how would I say, other activities in the communities according to what exists in your community. And then as well, looking at the farm workers, looking at taxi ranks. I already said this about through mobile testing. Churches, other events, go and try to get to the people when they meet, and the ones that usually are escaping the health center delivery services because they work, because they are at school, or because they just don't feel sick. We are also considering actively to look into oral self-testing. That is a new device that has now come out since several years. Still quite expensive, but it is very high, having a very high accuracy. And basically, we are definitely considering this as a potentiality to make people aware, have them testing with saliva, on their saliva, and then going with that HIV positive test on the saliva to the health center to have a confirmation test on blood before that we can start the treatment. So we don't have lots of experience on that yet, but we are actively looking into that, and hopefully within a few years' time, definitely we'll be able to add this up as another arrow on our bow. Testing in the community, testing at health centers, well, we could see indeed that basically we could increase in the last years the testing quite tremendously, but this was mainly due to the fact that we had the community testing picking up quite strongly. Unfortunately, KwaZulu-Natal, just like Lesotho in the neighboring country, is facing a big, sharp decline of number of counsellors for different reasons. Lesotho, because they don't have the money anymore, and that is maybe one of the dangers of mainstreaming HIV in general healthcare provision, is that, well, you are going to compete with other diseases, and therefore counsellors, who care about counsellors? We need nurses, we need doctors, and so why would we have to favor or prioritize one disease above another? Well, we see indeed how much indeed already this number of counseling activities went down in the communities, in the facilities, sorry, and we can even see that better in the next slide, by which the number of counselors is going to decrease from 32 up to 7, and we see that this has a direct relationship with the number of counseling sessions that are performed and testing sessions that are performed in the same facilities. So basically, indeed, here we see that counselors are tremendously important, for which as well this little film was, I think, trying to highlight this to the politicians and to the donor society a few months ago. But basically as well, that it is also important that we need to have a specific focus on these kind of diseases that need specific, how would I say, support, like counseling. You don't need counselors for malaria treatment, you need counseling for chronic treatments, just as TB, HIV, non-communicable diseases, and that's why we think that HIV still would need a specific attention for these kind of characteristics. Looking at the treatment and the retaining in care challenges we face on the field. So basically, well, again here, sorry for the slide, some things went down, but we can see indeed that when we started in 2011, by putting extra efforts, counselors, some extra clinicians going to the communities, we could quite steeply increase with the government the initiations of people on ART. And by adding up, indeed, only in July 2014, we started by including people with a CD4 above 350, so between 500 and 350, we could start having a little, how would I say, increase in the number of testing of people that are having a higher immunity still. Unfortunately, these data are only until 2014, and that only represents 5 months in the year. The programmatic outcomes, indeed, adherence is an issue, but we can still say that the majority of the people adheres well and is indeed remaining in care. So the remaining in care percentages are around 70 to 75%, which is quite comparable to other countries and not bad at all and encouraging, I would say. Loss to follow-up, indeed. The loss to follow-up percentage are related to that, of course, important. So we have to work on that. That is another priority for us. Dying has happily not anymore occurred as strong as 15 years ago. And TFO is transfer outs, people that go for another health center. We also need here to have special attention because people are moving where money is. People are moving for economical reasons. So we need to be able to have systems where we can guide these patients to start the treatment on one place and continue the treatment elsewhere. And that is one of the ways we try to do it as well, is for people that are mobile or for people that also have been counseled and tested in the community, how can they be linked for care and that we can encourage them to go for the treatment. I know you stood up, but I will still continue quickly. Remember, I showed you that many people still don't access treatment and have a quite staggeringly high or low CD4 count according to the statistics. And indeed, that's why we also have decided to go for a test and treat strategy that we would like to implement together with the government as from next year onwards, trying to tackle the number of people that don't access care yet. Challenges and adherence, I'm getting to it, don't worry. So you heard already about the 90-90. The 90% people need to be tested, know their status. 90% of the people need to be put on treatment and 90% need to adhere. Unfortunately, we are still staggeringly low. 55, 75 and 45% of the people are still not having an undetectable viral, are only 45%, sorry, do have an undetectable viral load. What is the picture in KwaZulu-Natal, in the population where we are? Well, you can see that we are not too bad maybe in some parts. So diagnosed, 82% of the people we expect are diagnosed. And 65% of the people do have a viral load under 1,000, do have an undetectable viral load. But again, what do we see? There is an age difference. This is the bar above 30 years old. These are my adolescents, for example, as well. The younger population, the less than 30, which are having much worse outcomes. And these are our priorities. These are our challenges. These are the key population that we need to focus on in our program for the coming years. So how we do that? How do we do that? Community activities. I think I will let Saar explore much more on that, but it is an active part of our activities. Just like I think Ophelia said this morning as well, let's be innovative. We have tried to be innovative and adapt treatments to the reality of the patients, bringing the treatment as close as possible to the people, but more detailed for that by Saar a very short time. And then as a conclusion, indeed, we need to work on all the levels of the cascade, on all the level of the steps that need to be taken into account, from prevention to retention and adherence. But we need to do that on a smart way. We need to focus particularly on age groups. We need to focus particularly on the gender issues, and we need to focus on where we, for the moment, still have not reached out to populations that are still escaping the offer of treatment and testing. And I would like to thank you very much for that opportunity. Thank you.